And what HCIN is it's public hospitals in California are sharing interpreters over a network. And so what that means is people are sitting at video phones, video units, and a doctor in Contra Costa who needs Vietnamese pushes a button, Vietnamese, and it looks for Vietnamese in his or her hospital first. And if there's no Vietnamese interpreter available, and there are a couple actually at Contra Costa, so that's why I'm mentioning Vietnamese. So it'll go to their hospital first, and if they don't find somebody there, then it rolls out to the other hospitals in the state. And when I first heard about video interpreting 10 years ago when Alameda County was first doing this, I was so excited. And the reason I was happy, I was a full-time Spanish interpreter. I was working at UCLA Medical Center. I love doing in-person interpreting. But who's interpreting for the Mandarin-speaking patients, the Korean-speaking patients, the Farsi-speaking patients? Where is the full-time employment in those languages? Hospitals cannot keep a Korean speaker, a Mandarin speaker busy all day long. And on a shared network, it becomes cost-effective for a hospital to hire, because what's going on is an exchange of minutes. So we give you minutes in Korean, and we get your minutes in Armenian. So that's the cooperative nature of this. So what is the in-house training capacity about? One of the things that we're interested in is we've got 53 interpreters that are shared. They don't work for HCIN. They're employed by their hospitals. And hospitals, as you already know, have evolved differently in their approach to interpreters. Some hospitals got hit by some complaint 10, 15 years ago. They were required, they were ordered to set up a proper interpreter service program, and today they have the best interpreter service departments in the state. Other hospitals have been getting by. They've been making do. They've been using what we call ad hoc interpreters. And so when people join HCIN, before they can be shared on the network, people have to have taken a course in healthcare interpreting, at least a 40-hour course, and they need to pass. Language Line has a test called Interpreter Skills Test. It's their entry-level hiring test. It's a challenging test. Not every bilingual is going to pass that test. If you haven't had a little bit of training, because the test does have medical vocabulary, it's not as high as what we might require someday in the future for a medical certification test, but it's a meaningful test. It's a meaningful assessment of language skills. But the other thing we're trying to do is give the working interpreters some, we want to use their skills. Some of these working interpreters could be trainers themselves. Some of them are people who've had a couple years of more formal interpreting training. 2 years at Riverside, UC Riverside, for example. Some of those interpreters are terrific. So we've got some people who worked 14 years for Language Line. So the range of skill that is in the network is quite something. And what we want to be able to do is take some of the more experienced people and equip them to train in other places. And to train, I'm not talking about training working interpreters, but bilinguals. I'm sorry if I'm but we're talking about a lot of these hospitals are using bilingual interpreters in their clinic areas, and they may or bilingual dual role employees. And now with the new state requirements, some of the hospitals are going, oh, I guess we're supposed to train them, or they've heard that, oh, the Joint Commission has started asking. They say, well, how'd you communicate with that patient? Oh, we used an interpreter. Oh, well, who was the interpreter? Oh, it was the medical assistant. Does that medical assistant have training in interpreting? No. Okay, so they're beginning to have these experiences. The Joint Commission may ask those questions. Also, the health plans now, because of SBA 53, may ask those questions. May come out to a hospital and do a site review. So they may ask those questions. So the bilinguals need a little bit of orientation to what is interpreting. And so this was our goal, is to multiply the number of trained bilinguals, people who will understand something about what is interpreting. And also for them to begin to recognize their own limitations. Sometimes a class in interpreting, a class in interpreting skills is what helps. It's almost like assertiveness training. Sometimes what they are able to learn is, doctor, I am not an interpreter. You need to call a qualified interpreter. And so sometimes that's the outcome for some of the individuals. But what we want to do is have more people understand what it is to be an interpreter. We want to lift up the talents of the trained interpreters, build relationships among the different hospitals. And this is a pilot program. We have some funding for this. Kaiser Community Benefit provided some money. It helps us pay the travel and hotel expenses of the employees. Okay, so that's the Train the Trainer project. And the reason I want to talk about this is kind of experimental. I want your feedback. I want suggestions. And I'm also looking for ideas about, if because this is a 6-month project, we might do this differently next year. We might have some different opportunities next year. So that's what I'm interested in today. As Nick mentioned, I've done a lot of training myself. I think a lot of us have done 40-hour trainings, and the people who come are, yeah, there's Lourdes. That's like exactly, there's Lourdes there now, right there in the middle. So LA Care Health Plan paid for lots of 40-hour trainings in Los Angeles. Kaiser Permanente has programs within its system. The Office of Diversity Programs does a 40-hour training. So there's a lot of people doing these 40-hour trainings. But despite, and that's a complement to the use of trained interpreters. So we have, on one hand, more and more trained interpreters, people who've gone through 2-year programs, people who have a certification, more and more training of the bilingual employees. And we want to give some training, because what's gone on now in California, particularly where we do have so many people who speak some Spanish, speak some English, a lot of systems have put all the responsibility for language access on the shoulders of untrained people. And this has been really unfair. I mean, I've called hospitals, like, well, who's in charge of your interpreter services? Oh, we don't have an interpreter service program. You know, everybody here speaks Spanish or Chinese. You know, we don't need interpreters. And yet we know that bilinguals who are put in this situation are facing all kinds of ethical dilemmas, their own limitations, and they don't know how to handle them. So this is the context that we're working in. The next slide. We have a lot of trainings, but of course the trainings that are available, there's more people who want them than can get them. At LA Care, a lot of trainers, you know, when I was teaching at LA Care, I told LA County, I said, pack them in. I'll take as many students as you want to send me. Personally, I didn't mind teaching 60 people in a class because I knew that, I know you lose some quality, and we could discuss that, but how many opportunities are there for people to get any information about what's the difference between an interpreter and a translator, what are some of the basic ethics of interpreting, give them a chance to practice their skills. So, and they told me they would send 1,000 people. If you know, that's how many people they want to put through training. And there's somebody in LA County, you know, going, you know, teaching group after group after group. So that's how many people we're talking about who might at some point want some training. So we need more